I thank clinical meeting organizers for giving us an opportunity to present a very interesting case that we followed up since last year, and we would want to share the journey of our patient. The patient was written off by two other fertility clinics because she was diagnosed with Asherman syndrome, and she came to us to SRH in the month of February last year. So I would just like to give an overview of what Asherman syndrome is, and then would want to go into the details of the case. So definition: Asherman syndrome is an acquired condition in which the patient has intrauterine adhesions, which um, poses a problem for conception and sustaining of a pregnancy. It's even called as intrauterine synechia. So the etiology we divide as two: gravid conditions and non-gravid conditions. So usually we see in post-abortal or postpartum curettage endometritis or endometrial ischemia followed by uterine artery embolization, usually done for cases of PPH, or miscarriage even without an invasive procedure, or cesarean sections. On a non-gravid condition, the most commonest in our part of the subcontinent is TB endometritis, post myomectomy, or uterine artery embolization for cases of abnormal uterine bleeding, or radiotherapy. So, what happens? Why do patients end up with this intrauterine adhesions? There is a damage to the basal endometrial layer. So, the basalis layer of endometrium is the one which regenerates the endometrium on a monthly basis. So, when there is an injury, either by infection or a post-abortal condition, there is an injury to the basal layer, and below the basal layer there's a layer called niche, and if that gets affected, there is a loss of there's a scar formation which leads to adhesion, and there's a loss of cavity integrity and endometrial function, which actually affects the implantation and menstrual irregularity. And if the patient is unaddressed, this is very progressive, and the patient will end up in infertility. So this is a small picture showing the endometrium with basal layer damage, which leads to atrophic glands, a pale and anemic microenvironment, because there's no growth of new endometrial tissue because of hypoxia and fibrosis and scarring. So how do these patients usually present? Usually they present with hypomenorrhea, that is very, very less menstrual bleeding, or even amenorrhea, months of not having their menstrual bleeding, or they can be picked up when they come for an infertility workup, or they might have a clinical presentation of recurrent pregnancy loss, of recurrent abortions, or patients might present with severe lower abdomen pain during menses, a pelvic pain even without non-menstrual cycles, and a history of any uterine surgery for myomas, or prolonged PID which was treated. So this is the way they present with varied positions when they come to us. So these are the presentations. So the gold standards, how do we pick up an intrauterine synechia? The best is hysteroscopy. Here there's a picture, comparing how it looks. A normal uterus without Asherman syndrome, and one with intrauterine adhesions, the second one. So coming down to our history, Mrs. and Mr. X were married for 6 years. They were diagnosed with primary infertility, and they were referred from a hospital in Tiruchi with dense uterine adhesions for further follow-up in Ramakrishna Hospital. So the patient had initially given a history of regular cycles, but over the past 4 years, her menstrual flow had become progressively reduced. So much so she came to us with very scanty flow, with bleeding less than a day or so. So they were married in the year 2017. They had tried for pregnancy over a year, and when they did not conceive, they had approached a fertility hospital in 2018, where a diagnostic laparoscopy and a hysteroscopy was done. This was the finding for her. So the uterus was normal in size, but there were flimsy adhesions, especially in the peripheral area, with bilateral tubo-ovarian mass. And hysteroscopy had shown a very small uterine cavity with thick adhesions, which they had proceeded to, do an adhesiolysis. With much difficulty, the ostia was seen, and it was mentioned in the case report that there was no normal endometrium seen. In view of tubo-ovarian mass, the patient was TB-PCR was sent, but it came back as negative. But in view of the clinical presentation and the intra-op finding, patient was given ATT. But patient lost follow-up with the fertility clinic. And in 2023, they had the patient's mother's family is in Tiruchi. So they had gone to one of the fertility clinics, which is run by one of our alumni, Dr. Kasturi, who passed out from Sri Ramakrishna Hospital. And she had done the second hysteroscopy, owing to the previous history for the patient. And she too found a small uterine cavity, which was constricted with thick adhesions, and that she referred to Ramakrishna for further treatment and management. So she ended up with us in February 2024, and hence when they came in, they underwent a complete infertility workup. And here the patient was found to have PCOD. Her day 2 ultrasound shown antral follicle of 26, and husband in her semen analysis was found to have oligozoospermia. A sonohystogram done showed a mid-cavity echogenic foci, which was more suggestive of intrauterine adhesions. Keeping her previous history and the findings in our hospital, we had decided to plan for a repeat hysteroscopy with adhesiolysis and endometrial rejuvenation with PRP injections. The patient was worked up for surgery, and patient was given injection granulocyte colony factor few days before the surgery, and a homologous platelet rich plasma from the patient was prepared on the day of surgery by a team of biotechnology from Bangalore who are working in PSG. And this PRP is very, very rich in stem cells and growth factors. So these are the hysteroscopic pictures of the patient on the day of surgery. And when we went in, there was dense adhesion, and the internal from the internal os up till the fundus, and there were also some thin scattered adhesions. Adhesiolysis was done with scissors, and lateral and fundal metroplasty was done, and the PRP, which is rich in stem cells and growth factors, was injected subendometrially at all corners of the walls of uterus. And after the adhesion released, both the ostia were visualized, and a copper T was inserted for the patient, and she was started on estrogen gel for 3 weeks, and she was regularly followed up. So after 3 weeks, the copper T was removed. She was given medication for withdrawal bleeding, and this withdrawal bleeding, the patient came back telling that she had a normal flow. Till now, she had experienced a scanty flow, but definitely there was a change in the thickness of the endometrium, and she had a very good flow. And as the action of PRP lasts for a few months, up to 6 months, we had planned to go ahead with HRT treatment and an IVF stimulation with antagonist protocol in the month of October. She on oocyte retrieval, 26 oocytes were retrieved, 20 were in metaphase 2, mature oocytes. 14 embryos were again all frozen and planned for 18 the next cycle. So she underwent embryo transfer in the month of October. A 2 grade AA blastocyst was transferred. Her pregnancy journey started with a beta HCG being positive. She conceived in the month of November. The following month, she conceived. And patient had a very stormy early pregnancy time. She was admitted at 8 weeks with a threatened miscarriage, which we boldly handled and was treated conservatively. At 18 weeks in her scans, she was found to have a short cervix, for which she underwent a cervical circulage, a modified Shirodsky. At 20, and she had come for a very close follow-up at our hospital, and she was monitored, fetal maternal monitoring was done. At 29 weeks, she presented with multiple episodes of bleeding. Steroid cover was given. In view of this persistent bleeding, she underwent an elective cesarean at 30 plus 5 weeks on the month of May this year, and she delivered a preterm healthy baby with an Apgar of 8 and 9 and weighing 1.3. The baby was admitted in NICU. Excellent care was given by the NICU team of our hospital. The baby was admitted for 7 weeks and went home healthy. We just wanted to present our happiness with us. Thank you.
Where there is the intrauterine adhesion, this is the place which is required for implantation of an embryo. And whenever such cases come, we cannot be giving it up and telling them to go in for a surrogacy or for an adoption, which was advised elsewhere. We can give an attempt and try for a conception, which we were able to do because of our NICU team and a good maternal care. Thank you.
We run short of words to congratulate you. You have made use of all the available gadgets and brought a new, ushered in a life into this planet. Really, my heartfelt congratulations. And we are all really amazed and thrilled at the scientific advances. And this is the auditor's webinar, the reason for you are choosing the embryo transfer. Had it been normal spermic, would you have attempted it or gone in for natural way of?
No, because the tubes are damaged. It was a bilateral TO mass. So the functionality of the tube is not there. Even though the count would have been good, we still had to go in for this sort of a procedure. Because this gives you a better probability of pregnancy. IVF. Secondly and thirdly is because of the damage, we don't want the PRP effect to be lost and the adhesion should not come back. So prior to that, we had to put in a pregnancy for her.
Can't you do PRP again after 6 months?
We can do it, but how many times to subject the patient? So already this was the third hysteroscopy and patient will get fed up. Asherman was a scientist who identified this condition.
Before the introduction of, before the entry of hysteroscopy into the field.
Yes. This was diagnosed by a scientist who was working on infertility cases, and he diagnosed that such intrauterine adhesions can pose a problem for implantation.
Are the patients who were Asherman syndrome immune to endometrial carcinoma development?
No, not necessary. They can still develop it. Because they can be a scanty growth of endometrium, because sometimes, and they can develop.
Again, I congratulate Lakshmi madam for a case who was running from pillar to post. I brought the case here and she diagnosed endometrial carcinoma 3 or 4 years back and the patient is still alive.
Thank you.
There is a description of, you can correct me if I am wrong,
Yes.
I'm not a logician, but Asherman syndrome described even before hysteroscopy, I think.
It was described even before a thing. Correct. It was there.
My professors, Dr. Susila used to talk about this. I think it's one of the divine logicians. She used to talk about this a lot during our OBG postings. Okay, any more questions? So thank you,
Thank
madam,
you.
for a
Thank
nice
you.
presentation. Over to Dr. Indhiradevi for us.
Hello everyone, good morning. Today we are going to discuss about a little about a traumatic brain injury in children. What looks like a minor fall can lead to a severe injury in children. So pediatric TBA is often underestimated. In developing countries like India, there is an increasing incidence of TBA. So I will be sharing journey of two PICU kids here. This is the data from a hospital. Totally 42 children got admitted with pediatric with the TBI in our PICU. Among that, there are three categories. One is fall, that is either fall from bed or fall from terrace or fall stairs or balcony. And second one is RTA, and third is KIT, that is accidental fall while playing. So among these, the first two category can be prevented. Though injury may not be prevented, but impact is definitely prevented. So among the first two category, 5 in each have moderate to severe TBA. And this is a child, 6-year-old boy, who got admitted after fall from terrace while playing, as the parapet height was lower. This child tried to jump from one terrace to another, but unfortunately he fell down. A simple engineering change could prevent this injury. This is the admission vitals. Child was comatose and had shallow breathing with bradycardia, typical signs of pushing with brainstem herniation. Child was airway was protected and anti-edema measures initiated and taken up for pan CT. And this is the CT showing a fracture of the temporoparietal region, which extends to the external artery canal. Even child had a hemorrhagic contusion in the frontotemporal lobe. And the CT chest showing a lung contusion with laceration and moderate pneumothorax. Child was continued on neuroprotection, but within an hour, child had unequal people, and repeat CT was taken, which showed increasing bleed with midline shift. So child was taken up for emergency deconstructive craniectomy, and here the aggressive control of ICP is key in neuroprotection, and post surgery child was continued on medical management. So after 48 hours, even with the medical management of edema, child had intermittent ICP surges, and repeat CT was taken, which showed infarct in the parieto-temporal area with a persistent uncal herniation, and even child had a herniation of brain through ears were noted. So neuroprotection continued for next 3 days. After 6th day, the ICP clinically child was better, and repeat CT also showing mild decrease in cerebral edema, and plan was to wean the sedation. But child had another setback. The child had increase in lung pressures, probably due to the pulmonary contusion, and had bilateral massive pneumothorax. Even child had tension pneumothorax, and CT neck and thorax was taken to, which ruled out larger airway injuries, and pulmo and CTVS department consulted, and child was continued on ventilation with complete sedation. After 3 days, the pneumothorax was drained completely, and child was ventilator pressures were minimal, and then we tried weaning the sedation, but because child received more than a week high dose sedation, we couldn't decrease a single minimal dose of sedation. Child had severe withdrawal, so we end up doing a tracheostomy on day 12. Then wean from ventilator on day 3. So usually in pediatrics we'll be waiting for 2 weeks, not like an adult will not do tracheostomy in the first week itself. And child was continued rehabilitation, and the nutrition were titrated. Child was doing well, and tracheostomy was closed on day 41. Our plan was to discharge the kid in the next 2 days. But again, there is one setback, onset of new high-grade fever with seizure with respiratory depression, ending up re-intubation. And the CT taken during that time showed rim enhanced lesion, the porencephalic cyst with the dilatation of the ventricle. The cyst was tapped, and the fluid grew Acinetobacter sepsis, and child was extubated after 48 hours, and the antibiotics sulbactam and polymyxin B was continued for 14 days. Over the next 1 week, child had intermittent feed intolerance and stridor. ENT evaluation was done, showed suspected right abducen nerve palsy, which was managed conservatively. But on day 64, child had life-threatening stridor. And CT neck and CT thorax and CT brain was taken. CT neck showing mild narrowing of the hypopharynx with dilatation of the ventricle and the CT brain. So child was taken up for VP shunt immediately. Post shunt, stridor settled subsequently and continued neuro rehab. This child was discharged on day 76 after a long and resource intensive course. And the following title of polytrauma with TBA, severe TBA, and late onset ARDS with pneumothorax, and cephalic cyst with facial nerve palsy, right hemiparesis and vocal cord paresis, CSF otorrhea with meningitis, obstructive hydrocephalus, status post VP shunt, and opioid withdrawal syndrome. This is the CT at discharge. Child had gliosis of the right frontotemporal and left temporoparietal lobe, both hoop and counter hoop injury. This is the second child. 13-year-old boy is a brilliant rider in RTA. He was not wearing the helmet. He was thrown into the stone piles nearby. So wearing helmet can prevent this injury. And admission vital, child was comatose with bradypnea and bradycardia. Child airway was secured and anti-edema measures was initiated. CT was taken. This is a CT showing the fracture in the frontotemporal region with orbital fractures and with bilateral ankle herniation and tonsillar herniation. Child even had air in the carotid canal. So he was initiated on neuroprotection in the first 48 hours. And the day 3, child had sudden rise of ICP. CT was taken, which showed large frontoparietal infarct with midline shift and the devastating ICA infarct, probably due to dissection. So here the CT is complete absence of carotid in the left side, and there is a thin rim of flow contrast through the carotid artery due to dissection. And child was taken up for decompressive craniectomy. Post surgery, child was continued on neuroprotection. And after 48 hours, the CT was repeated. CT showed no interval change in the edema, and child had central retinal artery occlusion, and also child had CSF rhinorrhea. So neuroprotection was extended next to 48 hours, and child was weaned slowly and extubated on day 8. So though child was extubated successfully, we had a worrying concern that child had persistent high-grade fever spikes from day 2 onwards. So even with the broad spectrum high-end antibiotics and his repeated cultures were sterile, and the septic screen also not conclusive. It was in the lower normal range, but child was hemodynamically stable. So this is a fever pattern. At admission, we started him on ceftriaxone. After 48 hours of the fever spikes, we escalated to Miro Vanco, and on day 9, he was persistently having the fever. So poly-B was empirically added with the background of CSF rhinorrhea, considering the possibility of meningitis. Usually will not add poly-B when hemodynamical instability is not there, but here meningitis we consider, we added poly-B. But even with poly-B, there was no improvement. So at one point we stopped all the antibiotics, considering it could be a fever due to central cause. So almost more than 5 days child was off antibiotic. Again the fever pattern changed, high grade 104, 105 was there. So we again restarted Miro and Vanco, and throughout this period child was cultured every 3 days, and the culture on the 25th day, that is the 7th culture, grew Candida species. The child was responding well to fluconazole. Usually we'll add antifungal if any hemodynamic instability. Without this, but the child doesn't have any hemodynamic instability, so waited till that. So the next weeks, in the meanwhile, child had feed intolerance also. Initially we thought of because sepsis, but even after fluconazole, child had feed intolerance. We tried hydrolyzed feeds and even smaller liquid gastric feeds with a prokinetic drug, but nothing helped. Again, after consulting gastro, we tried transpyloric continuous feed. We couldn't wean the transpyloric feed till discharge. The child was discharged with continuous feeds only. And after 1 month, over period of 1 month, child was weaned slowly. So oral feeds were initiated. So after 1 or 2 weeks, child started having intermittent vomiting, headache, and feed aversion. And the repeat CT was taken, which showed hydrocephalus. Plan is to do shunting the following days. This child with a tidal cord of TB with decompressive splenectomy, ICA dissection with infarct, central retinal artery occlusion, and Candida sepsis, severe feed intolerance, and hydrocephalus. This is a picture of the two kids who are doing quite well. They are able to stand with support and vocalizing. Their cognition and comprehension is quite good. And to summarize, both the children had severe traumatic brain injury with hydrocephalus and large infarct and nosocomial sepsis. Each of these diagnoses required a specialized and coordinated PICU care with involvement of multidisciplinary team. Throughout this journey, the family is burdened emotionally and financially. So, children who are playing are now hemiplegic is an emotional burden to the family, and long-term caregiving is a psychological stress post-discharge to the family. So, unsafe terrace, no helmet, no child car seat, no child-proofing home can lead to devastating injury in children. So these injuries can be prevented. Awareness can save the lives. As a healthcare professional, we should urge the need for public health education and enforcement of the child safety norms. So, pediatric TB is a critical public health issue. Prevention is more powerful tool than any ICU intervention. And I would like to thank. This is a teamwork. Without neurosurgical team and PICU team, PICU staff, and ER and other rehabilitation, speech therapy and physiotherapy team, they did excellent work in bringing the child up. And our next door neighbor adult ICU team and other subspecialty and our counseling team.
Thank you, madam. It's a very nice journey of two interesting patients. Any questions?
Very good thought. My question is, what's the neuroprotection strategy for these patients?
Complete sedation, sir. Will complete sedation. Sedation. We have a sedation score. In the complete deep sedation will prefer. Probably with the opioid plus add-on drug. And second, anti-edema measures will be targeting the sodium more than 145 and mannitol also whenever there is a acute surges. And typical ventilatory strategies, pH, no acidosis, no hypercarbia, no hypotension, no hyperthermia, no hypoglycemia, and head end should be elevated at 30 degree to augment the better brain perfusion and venous drainage. No, sir. No. We'll prefer euthermia, sir. No hypothermia.
Pediatric surgeon.
Yes, sir. Tracheostomy.
She's really struggling. Just temporal lobe. And that's Ramakrishna Hospital acts platform for so many wonders to be done. Our
most of the tends to be due to kidney and there will be fracture, minor fracture, gross edema, and they used to ask that very morbid fracture and all, minor fracture, how can it be good? He would say, even without fracture, in little things, there is a problem. But I have not much encountered pediatric injuries. Apart from pediatric, adult injuries, especially due to low Rajagopalan said, fortunately it didn't come to us. What should be the height of the parapet wall?
It's more than 10 feet. Sir, sir, it should be 3 feet, 3 feet, sir. 3.3, 3 to 4 feet.
So it will be protected with other some
Railing should be this, sir.
railings or
Yes, sir. It should be vertical, it should not be horizontal. Sir, in the railing,
Should there be sharp
no, sir. It should not be sharp.
glass?
No, sir. It's also not preferred.
Sir, questions to the architects.
The thing is, both children had a house
Yes, sir.
because Asherman doctor going in CSL and other and a surface the third, fourth microorganisms. And I think Lonan also put a candid, fluconazole quite early in the course. Somebody is not responding with the usual treatment. And what we are going to do to prevent this so-called nosocomial acinetobacter, even in adult ICU, it is right and left, it is there.
Sir, this child had a series of basic skull fractures, a series of autoria.
Whether we can do anything like restricting entries and
Hand hygiene.
hand care and other things.
Yes, sir. Yes, sir. Definitely, we can prevent nosocomial sepsis, sir, up to a certain extent, with the proper hand hygiene and proper isolation of MDR species. Children with MDR species isolated, sir.
And both children, that stay was prolonged mainly because of the infection.
Yes,
At least 10-15 days they should have gone earlier if infection was prevented.
How severe the injury, we must try to save the child. Neurosurgeon's work is just a decompression or shunting or anything. But the post-operative care is more important. The PICU team is very strong. Any child can be saved.
Thank you, sir.
These two children are saved because of your good teamwork.
Thank you,
And both the children had left-sided brain injury.
sir. Yes, sir.
Is they are talking now?
Yes, sir.
Understanding?
Now, yes, sir. Yes, sir. Their comprehension is
So-
very good, sir. And first child, now he is able to talk 2 words sentence. And second child just started vocalizing, sir. He will also come.
So we should not give up treatment, especially in pediatric children.
Yes, sir.
Adults, sometimes we may give up. So they become vegetative. Pediatrics, they carry a very good prognosis as far as head injury is concerned. Thank you.
Does not cross blood-brain barrier well. So, do we use any intrathecal or anything?
No, sir, we didn't use. A child had hydrocephalus also, we didn't use. So, since child had a.
Only to the
Yes, sir. That's why, sir. That's why we thought.
So, if no more questions, we'll close the session today. So, thank you, Dr. Indhiradevi and Dr. Lakshmi for their interesting presentations. Thank you all.